الدكتورة داليا لها مجهود عظيم في الاسم وفي الجهاز الهضمي، وأنا بعتبرها جوكر الاسم، فأنا بس نسيت أشكرها في الكلمة الأولانية فحبيت أديها حقها دلوقتي. ونبدأ إن شاء الله. لا حقيقة فعلا هي جوكر الاسم حقيقي. هنبدأ بقى بالكارت الرابح في اسم الأشعة. مو صلاح من الناس الواعدين اللي يشرفوا اسم الأشعة فعلا في أي مكان. اتفضل يا محمد.
Good morning. I have two stories today. The first is quite common and the second is salient. So I'll start with the first one. Here we have in our first story a 33-year-old female. She presented to the emergency department with acute abdomen. The preoperative imaging revealed a colonic mass involving the right side of the colon. The patient underwent right hemicolectomy and early transverse anastomosis. On the third post-operative day, the patient suffered from increasing yield from the post-operative drains as well as increased leukocytic count and increasing abdominal pain, so post-operative leakage was suspected. Here in this image we can see pneumoperitoneum. It was already discussed in the first lecture, so I won't go through these images. I'll go quickly for the sake of time through this image stack. So here, as we scroll, we can see at the site of anastomosis, there are air foci, as well as increased, there is fluid attenuation surrounding the iliotransverse anastomosis. So I'll point with the mouse. Here we can see at the site of anastomosis, we can see air foci traversing the wall. So this could be a suspicious sign for leakage, as well as putting in mind the pneumoperitoneum as well as the fluid attenuation seen. So we will go through the next image. Here we can see the heterogeneous amount of the heterogeneous fluid here in the operative bed adjacent to the anastomostic site, as well as the air foci localized around the site of anastomosis. So we will have a close look at this type of fluid. As we see here, this fluid shows heterogeneous density. So it was suspected to be leakage at the site of anastomosis. Here in the next slide we have two stack of images. The first one was not a delayed image, and the second one was delayed. I'll go for the sake of time to the region of interest. So here, as we scroll down, we can see this heterogeneous fluid density seen at the operative bed. Here I will have a close look at the delayed images. So here we can see that this amount of fluid shows increased attenuation in the delayed images, and this denotes contrast extravasation. This case is quite common, and I bet that everyone here would be asked the same question by the surgeon: is there leakage or not? So this concludes the importance of delayed images in the imaging of post-operative cases. As we can see here that this fluid had a heterogeneous density in the early phase images. However, in the delayed images, you could quietly see the increased attenuation clearly and the contrast extravasation. So this would be the giveaway of this case. This is the final diagnosis of this case would be leakage after iliotransverse anastomosis. I'll talk about the pitfalls here. If you have a non-contrast image, you can compare it with the post-contrast image. However, if you do a post-contrast CT at portovenous phase, you should have a delayed phase to compare both phases to see that there is increased attenuation of fluid and to diagnose the post-operative leakage. Thank you.
present Dr. Muhammad Shaab. He will talk about recurrent perianal fistula, lnto ultrasound, comparison between pipe lane probe and 360-degree probe.
السلام عليكم. النهارده هنتكلم عن recurrent perianal fistula mapping, biplane versus 360-degree endoanal ultrasound, a reappraisal. First, why reappraise endoanal ultrasound techniques? Endoanal ultrasound is a cornerstone in perianal fistula assessment that helps us in fistula classification, internal opening detection, detection of any abscesses, sphincter integrity assessment, and surgical planning. There are multiple probe designs exist. First, the classic 360-degree endoanal ultrasound, which provide a 360 circumferential 360 field of view, and there is the pipeline probe, which provide two perpendicular planes, axial plane, which provide a 180-degree field of view, and a longitudinal plane. Our case for today, a 65 years old male, not diabetic, not hypertensive, presented with perianal pain and recurrent perianal opening and recurrent pus discharge since 3 years. By clinical examination, we found perianal opening noted at 9 o'clock with pus discharge, and there is palpable tract is felt extending along the posterior anal wall by per-rectum examination. Before this patient was referred to us, he underwent 360-degree endoanal ultrasound, and here are some of the photos obtained. As we can see here, the hyperechoic structure is the external sphincter, and the internal hypoechoic structure represents the internal anal sphincter. And as we can see here in the first photo, there is a hypoechoic tract traversing the external anal sphincter. Also, we can see here in this axial image, there was a hypoechoic collection representing an abscess in the SQ anal space, and in this longitudinal image, there was a hypoechoic tract in the SQ anal space and traversing the internal and external anal sphincter. So the conclusion was this was an SQ anal space with transsphincteric fistula. Then this patient was referred to us for reassessment. We used the pipeline endoanal ultrasound for the examination, and here are some of the photos obtained. First photo, as we can see here, first the hyperechoic structure represents the external anal sphincter. As we can see here, the red arrow is referring to the subcutaneous opening and extend to a hypoechoic tract along the SQ anal space. In image number 2, we can see still see the hypoechoic tract extending upward, and the internal anal sphincter starts to appear, this hypoechoic structure. Then in photo number 3, we found that there is a hypoechoic collection with two branching tracts, secondary tract. One of these tracts, this is the internal anal sphincter, and this is the external anal sphincter, and this is hypoechoic tract extending in the SQ anal space. In image number 3, we found that the hypoechoic tract extend to a collection, hypoechoic collection, with two secondary tracts, two limbs. One of the limbs is seen traversing the external anal sphincter and to the internal anal sphincter. In image number 4, we can see that this secondary tract is also traversing the internal anal sphincter with defect in it. Here we can also detect the exact location of the internal opening, and it was a 4 centimeter distance from the anal verge. And here are some of the axial images obtained. We can see here the defect in the external anal sphincter. Here also, this defect in the external anal sphincter and extending to the internal anal sphincter. So our conclusion was that there was a right perianal branching Y-shaped transsphincteric fistula extending external opening at 9 o'clock and internal opening at 7 o'clock, position 4 centimeters from the anal verge, associated with an abscess at the confluence of the branching fistula, averaging roughly 1.5 centimeters. This patient so the biplane added values over 360 was it makes us to detect the exact location of the internal opening, detect the secondary tract extending from the abscess, better in assessing tract direction, and it gives us more detailed image, especially in longitudinal planes. This patient underwent surgery after 1 week of our examination, and this photos from the operation and confirmed our finding. So we transfer to the learning pairs of endoanal ultrasound in perianal fistula assessment. It is excellent for sphincter anatomy as it clearly delineates the internal anal sphincter, the external anal sphincter. As we can see here, the hyperechoic structure, the external hyperechoic structure is the external anal sphincter, and the hypoechoic, the internal hypoechoic structure is the internal anal sphincter. So it makes us able to delineate its integrity. This makes it very accurate in intersphincteric fistula and low transsphincteric fistula. Any hypoechoic tract equal fistula. Active fistula tract appear as a hypoechoic or even anechoic tubular structure. If it is a chronic tract, it will appear more echogenic walls. Air or pus may produce dirt shadowing. So the pearl here to scan slowly in 360 rotational mode to avoid missing any thin tracts. Here are some of the common pitfalls of endoanal ultrasound in perianal fistula. It is limited in complex fistula. It poor at detecting suprasphincteric and extrasphincteric, so MRI is superior. Active inflammation can mimic tracts, so abscesses or granulation tissue or scars. It will give us false positive results. Of course, it is an operator-dependent technique, and also the pain limits the examination. Internal opening may still be missed. So absence of a visible internal opening does not exclude the fistula. Thank you.
The next speaker, Dr. Mariam Hamdi, Assistant Lecturer of Radiology, Mansour University. She will introduce self-diagnosis of anastomosis, anastomotic leak after right hemicolectomy.
هنتكلم النهارده عن case of anastomotic leak after right hemicolectomy. دي female patient كانت عندها right side of cancer colon و underwent right hemicolectomy. البيشنت جايه suspected leak. انا هسيرش فور ساينز معينه of leak اللي هي ايه؟ direct و indirect. الدايركت هي الموست امبورتنت الموست دايجنوستيك، وابقى متاكده ان هو سبوت دايجنوستيك. طبعا اكسترا بوزيشن اوف كونتراست، ولو لقيت دايركت وول ديسكونتينيتي. الاندايركت ساينز الحاجات العاديه خالص، الاقي بيري انستموتيك فلويد كولكشن، الاقي جاس فوساي، الاقي ابسس فورميشن، الاقي نيموبروتينيال بيرزيستنس مش بيروح، او الاقي فيستولايزيشن او تراكت موجوده مش المفروض ان هي طبعا تبقى موجوده. طيب هنعرض الكيس الاول. اول فيديو هو من غير كونتراست، ثواني انا مش عارفه هو واضح ماشي. احنا هنا هنسيرش فور ساينز اللي احنا بنقول عليها. هي المفروض عامله اليو ترانسفيرس، فانا اكتر سايت هدور عليها نهايه الترانسفيرس وبدايه الاليو. لسه لحد الان طبعا ما بداتش السايت اوف انستموزس. دي الاستومك انتهت اهي خلاص. ده الترانسفيرس كولون اهو، وبدا هنا يكمل مع الاليو. هنا عندنا في irregular tract لسه هيبان اكتر، وفي هنا باين في fluid collection موجود في المنطقه دي. يبقى انا عندي شويه suspicious ان الحاله دي تبقى anastomotic leak او ليك وجه عام. اعمل ايه؟ طبعا ادي oral او rectal contrast. هنا الفيديو سريع قوي معلش ثواني. ماشي شكرا. هنا ميدلين ريكتال كونتراست. هنبدا هنا مع الادر ريكتم اهو، كمل سيجمويد، كمل ديسندنج على الليفت سايد هنا اهو. هنطلع فوق معلش ماشي لحد ما وصلنا هنا للترانسفيرز كولون. معلش تمام. هنا الترانسفيرز كولون اهو، كمل مع الإليوم اهو. هنا ده الإليوم، وبعدين الإيريجولار تراكت ده يعني المفروض الترانسفيرس كولون هيفتح في الإليوم بس، مش هيفتح في حاجه ثانيه خلاص. فهنا التراكت ده كمل وفي كونتراست لحد ما نوصل للسايت بتاع الكولكشن. لسه ما جاش معانا اهو السايت بتاع الكولكشن. هنا باين ان في كونتراست ليك. هي لسه مش هايبر قوي، بس لو قارنا ما بين الكونتراست والنون كونتراست هنعرف ان هو كان اصلا هايبو تماما. فكده اكتف كونتراست ليك ويز فيستلايزيشن ات ذا انستموتيك سايت. اخر حاجه هنقولها ان في ديفرنشال دايجنوستس دي الاذر اندايركت ساينز. مثلا يكون في بوست اوبرتيف نيوروتريم عادي ما هوش ليك، بوست اوبرتيف سيروما او كولكشن عادي برضه هيريزولف بمرور الوقت. هيماتوما حصل انجري بسيط لاي فيسل وعمل هيماتوما، فات ستراندنج اللي هم قالوا عليه، او يكون في ارتفاكت من السيرجيكال درين برضه زي ما الدكتوره ايمان قالت. وخلاص شكرا.
السلام عليكم. احنا بس هننتقل للسكند سيشن ان شاء الله، upper GI and bariatric surgery complications. الشير بيرسونز يشرفونا الالفابيتيكال اوردر: بروفيسور احمد الدين، بروفيسور احمد الحسيني، بروفيسور دكتوره داليا منير، and بروفيسور ايمان عبران.